Good evening, ladies and gentlemen. I am Indrani Malkani, Chairman and Managing Trustee of We Citizens Action Network. Warm greetings to all of you. Today's major talking point is the rise of black fungus, which is affecting COVID patients and which can be fatal. With so many messages floating around on WhatsApp, forwards going around, quite honestly, we are quite confused. Truly, how much do we really know about this disease? This evening, for our social Sanchar, as our guest speaker, we are delighted to have Dr. Sanjay Agarwal, Director of 8 Lake Clinic, Diabetes Care, Head of Department Medicine and Diabetes, Ruby Hall Clinic, Senior Consultant in Diabetes and Medicine, Jahangir Hospital. I invite all of you to freely interact with Dr. Agarwal post his presentation. This new challenge related to COVID-19, Mucor, sorry about that, commonly known as black fungus, much easier to say. It is vital for citizens, irrespective of age and socio-economic background, to know some of the things, at least, about this current challenge. What is the correct perspective of this challenge? The issues of spike in sugar levels of COVID patients, under treatment, and those recovered. The category of people who are most susceptible, and apart from black fungus, now we are hearing about white fungus and even yellow fungus. And even how does masks play a role in getting the infection? These are some of the issues why I shared with all of you, because these came through from many of the questions that we have already received and has been on pass to Dr. Agarwal, because it would be good to know what all of you want and what I would also certainly want to know. The black fungus is, it's coming into such proportions that we are pretty bewildered. And I'm sure that Dr. Agarwal will clear up all the fog in our minds. Before Dr. Agarwal is introduced and takes on his presentation, may I share a little bit about our organization. VCAN, the acronym of our trust, is a non-political and non-profit registered public trust, which is where the donations are eligible under ATG exemption from the Income Tax Act. Our overarching objective is to establish a linkage between the citizens and the government authorities. And we work in partnership with various statutory authorities in the state as well as with the local bodies. Our focus areas include health and well-being, air pollution, fire safety, road safety, waste management, electoral processes, among others. Many of you have been following our work and have been visiting our interactive web portal, TogetherVCAN.in, which deals with multiple issues on a single platform and such problems which affects a citizen's daily lives. Other than that, our regular social sanchars, which we call Together We Can social sanchars, are also followed by many of you. And your encouragement and participation gives us the enthusiasm and prime motivation for carrying on our work. With the ongoing COVID pandemic, we started our new series on health and well-being, which is a fully digital version of our normal social sanchars. And we hope that it will receive the same support that our normal social sanchars had received in the past and will resume once the situation eases. About the session format, post my sharing of my thoughts, my fellow colleague, Mr. Ranganathan, the former Chief Secretary, who has led the state of Maharashtra, as well as been the Commissioner of our Mumbai Municipal Corporation, will be introducing Dr. Agarwal, after which Dr. Agarwal will make his presentation, and thereafter the question answer will follow. I would particularly at this point like to thank our implementing partner, who are also our support partner for this social sanchar, Citizens Association for Child Rights, CACR. And I'm especially delighted to thank our college partner, Jai Hind College, their student council, the NSS students, and all the students of the college, and as well as many of the colleges that have been coordinated by our college partner. So we have nearly over 30 colleges which have participated, just come forward to participate in this social sanchar. I thank Team Technolegion for looking after our web portal and maintaining it, and also for conducting our social sanchars, digital social sanchars. I thank Mr. Sumit Lula, our social media consultant. And most of all, I thank you, friends, all of you, for joining us this evening. And I hope that you will seriously interact with Dr. Agarwal. May I now request Mr. Ranganathan, my fellow trustee, to introduce Dr. Agarwal. Mr. Ranganathan, please.
Good evening. I am pleased to introduce Dr. Sanjay Agrawal. Dr. Agrawal is the head of the Department of Internal Medicine in Ruby Hall Clinic and is also a senior consultant in diabetes and medicine in Jahangir Hospital and Apollo Group of Hospitals in Pune. He is a visiting faculty at Joslin Diabetes Center, Boston, USA, and secretary of the Research Society for the Study of Diabetes in India. Is a fellow of the American College of Endocrinology and is a much sought after speaker at various national and international symposia. He is also the author of a book, Clinical Atlas of Diabetes. So it is indeed, I think, fortunate that we have a person of Dr. Agrawal's caliber to enlighten us on the subject of today's digital social sanchar, understanding mystery of black fungus, which is that I think that it is black fungus is a common name. It is actually Mucor mycosis, and in particular, I was keen to know that it is said that this is caused partly by lack of hygiene in the hospitals where COVID patients are treated and administered oxygen. The humidifier is not sanitized regularly, sterile water is not used, and at the onset of black fungus, immediately cognizance is not taken so that it spreads. So we would like to be enlightened on this also, how the medical system is coping with this black fungus, which has come to the fore, I think, only in the last 2-3 months. Otherwise, earlier we were only talking about COVID-19. So with these words, I would request Dr. Sanjay Agrawal to enlighten us on the mystery of the black fungus. Thank you.
Thank you very much, and thank you for this kind introduction. Thank you, Mrs. Malkani, as well as Mr. Ranganathan. And I'll just take it over from here. Can I just share my presentation? Can you see my slides?
No, not yet.
Indrani, can
Not
you
yet.
see my slides?
No, not yet.
I did share it.
Yes. Now it
Yeah.
will come.
Now
All
it is coming.
Yes.
Okay. All right. Thank you so much. And I think it's a very interesting topic that I've been asked to speak today, and very relevant to the current scenario. Remember that COVID is something that is still we are trying to grapple with, and we're trying to learn new aspects of COVID since the time that it has entered into our lives. Sometime last year in March, actually, it hit India, and of course before that in the world. And since then, it has been always evolving, and we are understanding newer aspects of this virus every day. It's a very intelligent virus and keeps changing its faces like a chameleon. But we know that there is something that we need to keep, marching ahead of it if we have to keep our citizens safe and healthy. So I'm really going to talk today not much about COVID illness because I'm sure it's been covered by our previous episodes, but I'm going to focus my attention more today on the black fungus, which is creating news today. And every channel, every newspaper, or every discussion that you open revolves around the understanding of black fungus. As I just said, that COVID-19 is an enigma that no one understands. And if you look at the number of variants that have been picked up across the countries, you'll be amazed at how much mutations have happened about this virus. Currently, of course, the B1617 has been the one which has now overtaken all the other variants. And now it's not only it's relevant to India, but it's also seen in 56 other countries. We are also looking now as B1617.2 variant, which is now a little less harmful than the earlier variant, but it's more infectious and it spreads more rapidly. So you can understand how intelligent this virus is, that it keeps mutating all the time and keeps us guessing. Now, it's not that the mucormycosis is a new term. We've seen mucormycosis in the past, but more often than not, we have seen in our patients with diabetes in a specific condition, what we call as diabetic ketoacidosis. And if you look at the incidence of mucormycosis in the past, we would see generally most of us diabetologists would see maybe one or two or three in a year, not really very often. It's just that since the time COVID has come up, and we are seeing COVID becoming a rampant problem, and along with it, of course, the hyperglycemia or the rise in blood sugars because of the treatments, this entire combination, and along with other factors, have caused a sudden surge in the occurrences of mucormycosis. And these are some of the news that you keep seeing every day, which scares people. Currently, we have about 8,800 plus Mucor cases in the country, and almost about 2,000 plus actually comes from Maharashtra. We haven't seen this kind of numbers earlier. I was quizzing our ENT specialists and our infection specialists. The ENT specialists are operating almost about 5 to 6 or 7 cases a day, which is something which is alarming. So obviously, this is a problem that we are grappling with, and we need to sort of tackle it and see that we don't let it spiral out of control. We haven't seen in the hospital wards like this. We used to have better wards like for taking care, children's ward, gynecology wards, but having a mucormycosis ward was something that was unheard of. Now, let me try and make you understand what basically is mucor. It's a fungus, and it exists in the environment. It's not that something is just grown out of the blue. It exists, and it also mucus. I mean, the fungus is also as a commensal in the body. If you look at the nose and other areas, we do have as a commensal a natural presence of fungus, but it doesn't harm us. Our body tends to take care of it. It's only when you have an environment which depresses the immunity of the body that the body is unable to take care of the fungus. And suddenly you find that it becomes invasive and starts creating a problem. So these are the different, the mucor is a kind of a family which has different funguses. And I've just listed up some of these tongue twisters which I've mentioned on the slide. Now, there has been big talk that why does really mucor suddenly have become a major health problem? And this is what Mr. Ranganathan also briefly alluded to in his introduction. There has been a lot of speculations some associations, but we still don't know the proof of the associations. So one of the things that has really come forth is steroid overuse, because we have been using in moderate or severe cases high amounts of steroids, and at times it continues for a longer period of time. One direct correlation that has actually been seen is with poor sugar control, and that again is, as I just mentioned to you, nothing new. We have seen it in the past. It's just that we are now having patients who are uncontrolled, primarily because of treatments, primarily because of the disease, not because of the incidence of diabetes has suddenly gone up, and that may be one of the association where Mucor has suddenly become increased. Immunosuppressants, because you're sort of just killing the immunity, so any commensals then become pathogen, and they start invading the body. There has been a lot of talks about spore count, air conditioned filters, use of old masks. These are sort of something that we haven't proven anything. And mucormycosis is not spread by oxygenation, humidifiers, and water. The fungi remain in the indoors and outdoor environment, and they enter the respiratory tract via air. There has been speculation that when there is a breach of the lining of the air passages, then there is a higher chances that patients will tend to get, mucormycosis. There has been some association with zinc, because it's supposed to show that, that can sort of enhance the growth of the fungus. Similarly, the fungus uses the iron, ferritin, the free iron in the body for its growth. So there are some linkages with zinc as well as with iron, and that's something that we still we understand that may be one of the strong associations. So if you ask me, the strongest association comes with steroid overuse, poor sugar control, zinc maybe, iron yes, because it uses iron very closely, and overuse of immunosuppressants. So these are main factors that is actually causing the rampant use. Now, there has been sort of a lot of speculation about steroids and oxygens and drugs, and I too mentioned it some time back. So does it mean that every patient who uses an oxygen, or who gets a steroid, or who gets an immunosuppressant, does necessarily go and get a mucormycosis? I don't want to say that, because there are good studies, and this actually comes from Dr. V.P. Pandey from Indore. He's done a good population study, and we know that not every patient who gets oxygen, or every patient who gets a steroid, or every patient who gets an immunosuppressant, or those who have been in home isolation, they all develop mucor. It's probably a conglomeration of factors that, put together, makes the patient more prone to develop mucormycosis. So please don't get into your mind that if I'm going to be given an oxygen, I'm going to be heading for mucor, or if I'm going to be given an immunosuppressant or a steroid, then I'm going to be heading for mucor. Please do not have this. I don't mean to say it. It's probably contributing, but it's contributing to a whole basket of factors that may make you more prone for developing the mucormycosis. I just mentioned to you that there are too many dots to link, and we are still finding out what are more and more factors that may lead to increased propensity of infection with mucormycosis. Now, how do you really recognize that you're getting a mucormycosis? Commonly, patients present to us with an eye swelling. There may be a vision loss. There may be a facial pain. And sometimes the patient may have a drooping of the eyelid or inability to move the eyeball. So these are some of the things that immediately draws the attention. Patients often complain of severe headaches, and there may be loosening of the teeth, or you may find there is a black color patch on the hard palate. And that's where actually the name of black fungus comes in. It's not that the mucor is black in color, but it causes a necrosis of the tissue, which looks black, and that's how the black fungus gets its name. There may be an aggressive sinusitis, and at times when it goes into the brain, what we call a cerebral mucormycosis, there may be altered sensorium or loss of consciousness. So these are some of the common presentations of mucor which draws attention. You may have even a black patch on the skin, what we call is cutaneous mucormycosis. And these are, although it looks horrific, but I don't want to really dwell on this, but these are some of the black areas which are necrotic areas which is seen because of mucormycosis. Now I'm going to change tracks and talk to you the 4 steps of managing mucormycosis. The first is, of course, timely diagnosis. 2 is reversal of the underlying predisposing factors. 3 is early and wide surgical debridement of the infected tissue. And 4th is, of course, rapid initiation of effective systemic antifungal therapy. So diagnosis, recognizing it early is of paramount importance, because the more you lose time, you're going to make it worse for yourself. So please do not try and hesitate to go to the doctor if you have any illness that sort of mimics something like this, because it may be that it's an early phase of mucormycosis, and the earlier you go to the doctor, it may come to the attention and treatment may be initiated. The key thing is we do is an MRI or a CT scan of the sinuses, and you need to get a good ophthalmologist and an ENT specialist to look inside and see whether the eyes and the sinuses are affected. Very often you have to do a functional endoscopy to make sure that you can reach the sinuses and see whether you can identify the fungus. Then we, of course, take smears of it. We take a punch biopsies, and then we sort of do a smear examination. If there is a bacterial culture, fungal culture, we do a histopathology, and then we come to a diagnosis. There are very few blood investigations that can actually identify. So the two, if I have to just put it in a nutshell, two key investigations is radiology, where you do an imaging to identify, and two is actually the physical examination of the mucor. Remember that if you diagnose early, you can be instituted treatment. And this is a very important study which said that if you delay the amphotericin therapy by initiating treatment even by more than or equal to 6 days after diagnosis, it results in a twofold increase in mortality rate at 12 weeks after the diagnosis compared with early treatment. So here's a clear data that the earlier the better if you have to sort of kill the mucor at an early phase. What about reversal of the underlying predisposing factors? Remember that we are using steroids, and one of the things that we commonly recommend is please do not use steroids in the early phase of the illness. Patients with mild disease do not require steroids. It's only when patients start becoming hypoxic, that means when the oxygen tends to start going down, there's the indication for steroids is there, and we start using steroids in patients who are having moderate or severe COVID disease, and often they're used for short periods of time, not more than 8 to 10 days. So, I mean, if there is a reason for using for a longer period of time, your physician will be the best guide and judge for it. Use immunosuppressants with caution, because very often patients get immunosuppressants, and we need to really justify the use from the medical profession that yes, this patient is an ideal candidate for immunosuppressant therapy. It does have a good role, and it should be used where required be. So your doctor is the best judge who can tell you that yes, this is the ideal case where immunosuppressants are required. Not every patient does require antibiotics, because remember, this is a viral disease. It's not a bacterial disease. So unless there is a clear evidence of an added superinfection with bacteria, we do not generally use antibiotics. And of course, the bottom line is a good sugar control. And this happens very often because patients with the stress of illness itself, the use of steroids, suddenly get a surge of high blood sugars, and then we have to start, trying to control the sugars. Please remember, in these sort of situations, there is no role for oral therapies. When you have a very sky-high blood sugars, only insulin is the way to go to quickly bring the blood sugars down. So your doctor may advise you that you need to take insulin treatment. Now, why are we really concerned about wide surgical debridement of the infected tissues? We know that there is a there's clotting in the blood vessels, which leads to sort of necrosis of the tissue. And if you don't remove it, there's a putrefaction that tends to occur. Also, this is avascular, so there is no blood flow. And remember that all treatments, all drugs are carried by the blood to the site. So if it's avascular, where there is no blood flow, your antifungal agents are not going to reach the area. So you need to remove all the putrefied areas, the necrotic areas. And remember that if there is a necrotic area, it can get added infection, and that can complicate the situation. So you have to remove all the dead tissues so that there's a healthy tissue visible. And then you, of course, attack it with antifungal agents and, if need be, an antibacterial where there is an added infection. Now, the main treatment actually comes from amphotericin B. You've got plain amphotericin B and the liposomal amphotericin B. The liposomal amphotericin B is a little more kidney friendly and we use it more often. It's used as a single dose. We give it at about 5 milligram per kilogram per day, and we give it generally for about 2 to 3 weeks of amphotericin B. There can be an adjuvant therapy with posaconazole or isoviconazole. If we can give icocandin, these are all the other adjuvant treatments that are given for a longer period of time. There is no short-term treatment with drugs when we use antifungal treatments. Very often we give it for 3 to 5 weeks antifungal therapy. There has been some role of hyperbaric oxygen, but these are not the standard of line therapy. The main therapy is, of course, using amphotericin B, and that's the treatment of choice. There are certain non-pharmacologic interventions. So there was some sort of talk about the humidifiers. So yes, of course, hygiene is always good. It prevents any infections, and we are very concerned about hygienes and using sterile water for humidifiers. We need to ensure that there is optimal ventilation, so HEPA filters. So if you see now, most of the aircrafts, when they're flying air bubbles, they have now changed over to HEPA filters in the aircraft. And similarly, in all our operation theaters and a lot of the hospitals are using HEPA filters so that it can filter out all these sort of unwanted things. Environmental controls are important. Daily cleaning, wet dusting to prevent aerosolizations, isolation barrier. Remember one thing, that the Mucor mycosis does not spread by person-to-person contact. It is always there in the environment. You need to have conditions where the immune barrier tends to go down, and that's when these commensals become pathogens. So it is not sort of something that you can get it by touching somebody else or eating with somebody else. That's not the way it gets its way to transmission. There's been some talk about white fungus, and this is what we, in medical terminologies, call it as invasive aspergillosis. Commonly, patients present with cough, fever, diarrhea. There could be dark spots in the lungs, and these are because of hemorrhages in the lung, because of the invasion of the fungus in the bloodstream. There could be reduced oxygen levels. There could be white patches in oral cavity, and there could be skin lesions. The other white fungus that we also see commonly in patients who are immunosuppressed is Candidiasis. These are sort of, you get thrush, oral thrush. You can have, in the private parts, fungal infections in patients with the highest blood sugars. You can have even in the gastrointestinal tract. But remember, any fungus, anyway, for any reason, is always an immunosuppressive state. So if you have a fungal infection, for sure, there is some kind of an immunosuppression that you've got. We also now, recently in the news, we've been talking about yellow fungus, and these actually develop in presence of molds in the environment. Patient often complains of fatigue, rashes, burning sensation of the skin. It invades the internal organs and affect the functioning. It can be dangerous, and there should be focus on the prevention. Remember that we have been talking about how can we prevent it. I think good hygiene and clean environment are two important aspects that we should really concentrate on. But important is the fact that you don't ignore your own health. If you have any medical predisposing factor, it should be treated as early as possible and brought under control. So I'm going to end my talk by mentioning that what do we do as a citizen? We need to act responsibly. And if you get a COVID disease, do not panic. We have enough medical care, a good medical care available in our systems. We are now understanding more about how to manage patients. There was time when we really didn't have any clue. People do accuse that, every sort of drug that we use has not proven to be useful. Yeah, that is true. It's an evolving science. We're trying to learn more and more about the disease, trying to learn more about what works and what doesn't work. For us to make a conclusive evidence, it takes time. It takes more patience. It takes sort of clinical studies. It takes research. So we need to have all this to give you conclusive answers. So please don't be disheartened by the fact that does drugs work? The answer is yes. We are saving a lot of lives. And if you look at the statistics, mucormycosis occurs in about 0.0034% of the total volume of COVID patients, which is about, I would put it as 3 per 10,000 patients of COVID. So it is a very low incidence problem that we've got, but nevertheless, if you look at absolute numbers, it is something that we need to worry about. Prevention is better than cure. Prevent COVID-19 by recommended practice. I would say COVID appropriate behaviors that we keep listening and hearing and talking about. Do not have an ostrich attitude. Consult your doctor early if you feel ill. It may make all the difference. Control your blood sugars tightly. Ensure you have your regular medical checkups. An educated patient is better than a misinformed patient. There's a lot of talk in various social medias and person-to-person talks, coffee tables. Please separate the junk from factual reading and listening. And don't be misled by sensational claims. Please remember that medical professionals are working round the clock to keep you well. Thank you very much for your patient listening.
So,
Thank
thank
you
you,
so
Dr. Sanjay
much.
Agrawal, for a very lucid and excellent presentation. Now, I think we can go for questions.
Yes. Dr. Agarwal, as we take up the questions, one of the things that came through, which you might throw light on, that when we talk about treatments and various medicines, what would be the costs involved?
Yeah, so
This
basically,
is a question often raised, and there has been one of the questions which will probably come up, but something you may want to just share as part of your talk, and then we go to the questions.
So it's really, honestly, if you ask me for an honest answer, it's very difficult to predict costs because it varies from place to place, from city to city, and the medical infrastructure to medical infrastructure. Also, the amount of resources that you have to use for an individual patient. So what I can really tell you in honesty is that the hospitalization cost is one part of it. Now, it may vary because what the hospital costs in Bombay would be different from Pune or from a place like, a smaller city like Baramati or, Latur. There would be different costs involved out there. So it's difficult to generalize. The medicine costs, that is something, procurement of the medicine is important. And of course, if the need for surgeries and care in the, the aftercare. So all this actually determines the cost of therapy. But nevertheless, if a patient is going to be requiring only hospitalization and drugs, the cost can be reasonable. But if the patient requires, let's say, repeated surgeries, because there can be repeated debridements that you need to do. If the case is more severe and needs, admission into the ICU and maybe, intensive care resources, then the cost can spiral out of control. So I really would not like to put a figure, but yes, it can be right from a very small amount to a large amount, depending on where you are in this point of time.
Thank you. Thank you very much, Dr. Agarwal. Okay, let us have the first WhatsApp question which had come. It had to do with a particular medicine, and I found that quite interesting. Can we have that question, please?
Yeah, okay. So I think sometime we have been sort of saying, okay, zinc tends to build up immunity and it's an immune booster. We now, of course, there has been a lot of talk about zinc being actually harmful because the fungus may use zinc to replicate and to grow itself. So these are, again, just sort of associations. We don't have conclusive research to say that, but there has been, through sort of scientific discussions, mentioned that when you use zinc for a longer period of time, short-term zinc use may be fine to use as an immune booster, as a prevention. But long-term zinc use, particularly if you have suffered from COVID illness, maybe you may want to avoid it at that point of time. So as a prevention, you can use zinc, but as an afterwards, maybe you should not use zinc for a longer period of time.
Here it talks about the vaccinations, to be had before the jabs, not after. That has to do with vaccination, I presume.
So I don't think zinc really has any relationship to vaccination. You can safely take, there is no really harmful effects of zinc where vaccination is concerned. I'm just relating it to mucormycosis. Okay,
thank you. But since you mentioned about zinc, one of the common things that have often been asked of us is that, the Vicosule, I think there is one combination with zinc. Such vitamins with zinc component, does that in any way have any issues in these
So if
times?
there's a very small quantities of zinc, it really doesn't matter. It's only when you
It
take
doesn't.
very high amounts of zinc, then it may have a role to play. So most of your B complex preparations will have a minuscule amount of zinc present out there as a, but that doesn't really make too much of a difference.
Okay, that's a good one. Okay, now let's have the next question. I think many of these questions have already been addressed in your presentation, but nonetheless, yes, definitely the early detection you have already talked about. But perhaps the comorbidities, is it only to be related to sugar, diabetes, or any other comorbidity also could contribute to it?
It's a good question. So I emphasize more on diabetes, but there are other immunosuppressive states. For example, patients who've got cancers, patients who've had transplantations. These are the other sets of patients who really are on immunosuppressive therapy, and these are the patients who should also be watchful for. So so you may have any sort of condition where immunity goes down, even steroids long term. So there have been patients who've been steroids for various other reasons. Now, there has been speculation that, okay, does all patients who get steroid develop Mucor? And the argument against it is we have been using steroids for a long duration of time. There are patients of arthritis who've been on steroids. There have been asthmatics who've been on steroids. There are sort of cancer patients who've been on steroids. So why do they not get mucormycosis? And I can only say that this is one of the strongest association where mucormycosis can occur. And as I mentioned in the course of my presentation, that it's a question of an overall basket of factors which suppresses the immunity, and not one of them in isolation can be responsible for development of a problem.
Okay. So you have already told us the risk factors and the early signs and precautions, etc. So are there any particular precautions that we need to add on to what you have already said because there's one question on that, but I thought let me just ask as an add-on here.
I think precautions, of course, therapy is very important. We have some direct correlations between, making sure that your sugars are under good control. So that's one of the strongest factors that we always keep talking again and again and again. And I want to re-emphasize that point.
Right.
The second thing is, of course, if you have been on immunosuppressants, it is wise that, you keep yourself well protected, because even sort of, wearing of masks becomes very important in public places, because you have a higher sort of indication for any infections to occur.
Right.
Ensure that you you have a periodic checkups. Any other situations which can, a good nutrition to build up your immunity, exercise daily, breathing exercises, all these things have a good role to play. Don't use unnecessary medications because somebody recommended to you, because a third person recommended that person. So these are some things we have no idea about proven values. So you have to look at what has been in the public domain, researched, talked about, at least even if it's been researched and discarded, but there has been a thought behind it. So you have to see that you're not going by word of mouth, but go by scientific literature.
Right. Thank you. Let me have the SMS questions, please. The first one. I think you have already spoken about the second part more, but it is interesting about the first part, about the age group. Is there a certain age group? I know you had touched upon the gender and certain other things, but is there anything that you would like to add on to this?
Yeah, so I think I did not really mention it, but it was there on my slide about the age distribution, and this came from the study by Dr. V.P. Pandey from Indore, and they found that there is a little higher incidence in the middle age and the elderly population as compared to the younger population. So I mean, there is a little sort of a bias there where it is more in the middle age and the elderly population. But yes, it can occur in all age groups.
Okay. Could we have the second SMS question, please? I think it's very interesting, the first part at least. What are the myths associated with black fungus? Are there myths?
Here's
the question.
I think the whole question about mucormycosis is a big myth by itself.
Many of them are already covered in the presentation.
No. Is it a myth?
No, it
What
No.
would
isn't.
you?
The thing
So
is,
there aren't any.
it's a reality, and we are
It's a
seeing,
reality.
patients with mucormycosis and, patients who are post-COVID having
Hmm.
a mucormycosis. So please don't
Hmm.
dismiss it, saying that it is a myth. We get this. The reason I mentioned is because I have had people who are talking to me and saying, "Does really COVID exist?" And I look at him and say, "Are you
Yes.
serious?" There have been people who have been questioning the very fact that does COVID exist, and then they come up and said, "Is this a media creation when you say about mucormycosis, and are they creating a fear complex?" And I'm really wondering that what should I answer these people? But let me tell you that mucormycosis is a fact. The numbers are real, and we are now terming it as an epidemic. Although it is grappling more with with Indian population, it's seen more in the Indian subcontinent. But it's not that we haven't seen mucor in other parts of the world, but probably at a lower incidence. The fact that we are dealing with this pandemic is a very, very realistic thing. Please don't dismiss it as a myth or it's a creation of somebody's imagination.
No, that is true, because the second part of it, it does say that what can affect on a COVID affected population. So I think what you were saying earlier, before your thing, that when we get herd immunity, so to speak, or we are vaccinated, would that have any difference later on? Right now, there is more COVID, and when there is the COVID eases, will there be any reason to think about it? Or
Yeah,
probably that's not the.
so Indrani, to really touch this very realistically, our problems are not going to end with control of the pandemic. What we are now more concerned about is what's happening to the people post-COVID. We are seeing increasing number of people who are ending up with stiff lungs, who can't breathe, who are breathless, and this is because of a lot of fibrosis that they end up getting in the lung. There are a lot of traumas to the lung because of prolonged ventilation that they have to get to keep themselves alive. We are seeing patients who are ending up with strokes, who are ending up with heart attacks, with heart failures, who are ending up with immune dysfunction. So patients, we end up with neurological disorders, and patients who are developing new onset of diabetes. So there are a host of conditions that are ending up in post-COVID, which people are going to be, dealing with in the long run and time to come. So it's really, really weird. It's something that we are not really talking about, but post-COVID problems are going to be of a high magnitude in time to come.
There's a question. I won't have the slide, but I've just received, so I'll just share it. Can one identify where the earliest case of mucormycosis came from? Do you have any
I
idea?
don't
You
think
said that
I don't think I have an answer to that. But as I said, that basically
it's a myth.
mucormycosis is not something which has been created now. We have
Hmm.
seen it for years and years and years in our patients with diabetes, specifically patients who have had diabetic ketoacidosis. So it's not something that we're really looking at it. This is something that just like COVID has come out suddenly, that
Yes,
that mucor has also come out suddenly. We always had it, but we're
right,
seeing it in a very far few populations. It was very specific in a subset of population. It's just
right,
that now it's spiraled out, but it's been there always.
right. Um, I have received another question just now. That, of course, part of it you have already covered. Uh, can vaccine lead to black fungus? As there is steroid. I did not know that vaccines had steroids. So
So,
that itself, does it?
so the answer to the first
No,
one is,
there's another part to it which I
now
shall
let me
just share.
first answer the first two parts and then we'll
Yes,
come to the
please.
third part.
Yes,
So, does vaccine lead to fungus? The answer is a big no.
good.
Please, there is no association between the vaccine and the fungus. Is there a steroid in the vaccine? The answer is again a big no. Let me put that very emphatically, that there is both the questions, the answer is a big no. Now I'll come to your third part.
Yes. Third part is a person with psoriasis, blood pressure, diabetes, of course, a vaccine similar for arthritis. No, there's nothing much in this question, this part of it. The big no's, the big two no's is what we have to highlight, which you
Sure.
just said. Yes. Okay. Let's go back to our question. Have you received live questions? I think live questions came more on this. Here we go.
All right. So is poor hygiene condition in a hospital responsible for this black fungus? The answer is that fungus molds are there everywhere. I mean, if it's there even in the house, why do you want to put it in the hospital? It's there everywhere in the environment. It just needs the needus, a background where you sort of have a poor immune status, which sort of just or a breach in the epithelium or the lining of the respiratory tract to invade the fungus into it. So the fungus is available everywhere. So please don't blame the hospitals for it. It's not the case. It is there everywhere. And most of the cases that we are seeing, fungus is all occurring outside the hospital
Really?
after discharge from the hospital for the primary COVID illness as such. They get
Okay.
readmitted for a mucormycosis, but it doesn't happen immediately that they got a COVID illness and immediately they also have a mucormycosis at the same instance. So it
Right.
takes some time for the immunity to go down and the fungus to invade and create a fungus mucormycosis. But
Okay.
yes, hygienes are always important. So let me not sort of hide the fact that hygiene is always good to prevent any infection.
Right. That to add to that, I've often been asked whilst we were, sharing the invitation to your session about masks being, the cloth mask. We are all told, and we all do that. Wash it regularly. You put it in the sun, and etc. etc. When you wear a mask for a long time, as in through the day, etc., the humidity, does it in any way contribute?
We have no direct association. We have no conclusion about it. So if I have to say that masks are responsible, we don't have any such conclusive evidence about it. But again, what is important is good hygiene practices. If you have somebody who's sweating very badly, who tends to, sort of have a lot of sputum contamination of the mask, because we do have organisms in our mouth, and obviously it will stay on in the mask. So it's good practice, if possible, to use the standard N95 mask, or if you're using cloth mask, to wash it every day or change your mask every day. It's not really very good hygiene to continue using masks, day after day without cleaning it. So that's something which is not a healthy hygiene practice. But we really don't know whether these masks have got some association.
When there are questions about certain, here you go.
Okay, so there's another question, that why is it occurring in India so much? I really don't have an answer to this, and I don't think anybody for that matter has an answer to this. Maybe the humid environment of our country, maybe that we are facing a more incidence of COVID in our country. So obviously, when you have a higher volume of patients, you see higher volume of complications too. Steroids being available over the counter, so people indiscriminately use steroids for various reasons. Population density becomes a very important factor for transmission of illnesses. So there are multifactorial, answers to this, but we don't have a very clear-cut answer to say that these are all speculations, honestly, if you ask me. So we don't have really a conclusive answer to say why is it occurring more in the Indian subcontinent. But we just, after USA, we have the second highest population of patients with COVID in the country. So obviously, if you look at absolute numbers of COVID, and even if I say it is 0.0034% of the number of population with COVID, just multiplied for the volume of patients that we are seeing, it does amount to a large number overall in absolute numbers.
Right. We in your presentation, you did take up, while the question comes, may I just ask, which also has come earlier, about the three types. Okay, perhaps you may take this question, then I'll ask the other one.
So there's a question, can soreness in the throat due to acid reflux be mistaken for fungal infection? More often than not, the patients rarely present with rhinocerebral or rhinocerebral ophthalmic mucormycosis, where the sinuses, the eyeballs, and the brain tend to get affected. It's only when the hard palate gets involved, where there's a necrosis of the hard palate, that you tend to get. So patients more often than not present with a facial pain, with headaches, with eyeball pains, vision losses. These are the common presentations. Only a simple sore throat, less likely. But you can have a postnasal drip which can cause a soreness of the throat, but it is not one of the presenting feature of mucormycosis.
Okay.
But you can get, because of acid reflux soreness, because of acid reflux, you can have acid pharyngitis. And because of acid pharyngitis, you may get a soreness. So don't extrapolate that to say that I'm getting mucormycosis.
I think that emphasizes the fact, don't panic.
Yes, I mean, that was my conclusive statement.
Yes.
That, please do not panic. Everything
Be
that
alert.
you feel, everything that you get necessarily may not be COVID or may not be really mucormycosis. It's just that you have to have a high index of suspicion, to go to the doctor and verify that, okay, do you have a problem, so that you don't have a laid back attitude and allow the fungus to grow to lead to problems. So if you have a whole constellation of symptoms which may be sort of indicative of mucormycosis, it is wise to go and check with your doctor to say that, do you have it or you don't have it. But once he reassures you, please be at ease that you're good. That's it.
Right. So then that brings us also to another question, which I think you have already covered. That does black fungus happen to people who have not suffered from COVID? It can happen to anybody or not?
As I said, that we have seen it in our patients with diabetes. We've never had COVID. I mean, this has been for years together. We have seen it. So it can happen, but
it can.
It can happen, but it's been seen more in patients with diabetes more than anything else.
Right. Tell me, doctor, we talked about the 3 different colors. We are very colorful life these days: black, white, and yellow. Now, if you were to grade it, is there any grading that one is more dangerous than the other, or whatever?
No, I don't think we really have that.
In a very simple way, because it has come through in talks.
Yes. Remember that basically the fungus is not colored. It's the tissue that it goes through that gets affected, that colors it. But these are all sort of, opportunistic organisms. They stay quiet, right? But it's only the gates get opened up when you have an environment which makes it conducive for it to get inside and create the havoc. Now, again, it all depends on what your immunity levels are and how strong you are. So there is, let's say, one end of the spectrum, you have patients who have mild illnesses, who get over it and the matter is over, just with medications. On the other side, on the other end of the spectrum, you have got patients who are critically ill, where you've got extensive involvement of the fungus. So I wouldn't say that is white fungus more harmful, or is yellow fungus more harmful, or is mucormycosis or black fungus more harmful. It's just basically, it's the tissue that it invades, the number of organs that get involved makes it bad. So each of these funguses can be harmful and destructive when it reaches the right level, which it sort of finds an environment in which it grows and targets the target organs.
Right. Very, very interesting. Now, here we have you all. You have already answered this.
I think I've answered this.
Yes, you have.
But just to answer to fairness, that do all COVID patients tend to get mucormycosis? The answer is a big no again. I don't want you to start thinking that if I have COVID, I'm heading for a mucormycosis. Please, that's not the case. I said the statistics are just 0.0034% of the population with COVID who tend to develop mucormycosis.
Great. Doctor, there will be more questions coming in. And I would like to also share, we have created on our web portal a dedicated page, which is called Health and COVID. So although we call it the Health and COVID because this is the current times, and since a lot of information needs to be collated in one place, if there are issues that you think that we should put up, apart from your talk, of course, will be featured there, could we please have the slide with the link to the Health and COVID page on our portal? If you can just have it out. I would invite all our viewers to visit the Health and COVID section on our portal, because all of this will find place in this page. So I think as we go, and if Dr. Agarwal would like to share in future, after the session, any particular updates that you think relevant, we would certainly publish it so that people are updated with the correct information and not what is just going around, in the social media directly. Let's use social media for good. So
I'll be
we
happy
would
to
do
answer
that.
any questions if they come up later too.
Yes, thank you so much, Doctor. To all our viewers, I would like to say that we have put up a Google form. So do try and fill it up and send it to us, because it would be nice for us to know that what interests you more, and we could definitely, focus on those areas. And feel free to tell us which segment of this particular session that you found. I found the whole session very interesting. It's very riveting. And do share your points of view as well. That would be nice.
Thank you.
Dr. Agarwal, normally, if you were to have a session face-to-face, today in the digital world, there are no borders. We are all over the place. I must say our IT team, which is doing all our back-end work, is based in Bengal. My social media consultant is sitting in Rajasthan currently. I and Mr. Ranganathan are in Mumbai, and you're sitting in Pune. And we have viewers and friends all across, not only just in India, but elsewhere in the world. So there are no borders. So I think digital ways have really connected us in so many ways. So because we are not able to meet face-to-face, it is with great pleasure that on behalf of our trust, we thank you with a virtual memento. And we really hope that there will be more sessions with you in coming times, perhaps not on Black Fungus, but there will be so many others, because your primary thing of diabetes is a lifestyle issue. And I think we will always be having, questions related to that. So is there anything else that you would like to add or want all of us to know?
Yes, I would just like to first congratulate you on the wonderful work that you're doing through your network as well as through VCAN. I think it's so important to have something like this, which connects the entire citizens to what reality is, as well as links them up to various authorities. I think your organization is doing a very great work, and thanks to you, Indrani, as well as Mr. Ranganathan, for spearheading this entire movement. I'm sure it's going to pick up and go a long way to connect everybody together, and I'm sure it'll make a lot of changes in the society. The other thing is, as I'm also the National Secretary of the National Body of Diabetes, the Research Society for Study of Diabetes in India, the RSSDI, I want to say that the RSSDI has always stood for how we can manage patients with diabetes. We put out advocacies, the advisories, the guidelines, and we are all there from a national body to see that we can make patients with diabetes, we can make their life better. We have a number of initiatives that we do through our bodies. Please feel free to approach us if you have anything related to diabetes from the national body. I'm sure we will extend all the help possible. Wherever you are, whichever part of the country, I'll be very happy to extend help to all of you. And please do not, I want to end up by saying that we are facing a pandemic, and it is a grave problem. It is affecting lives of people, but we can make it better by having a positive attitude. Please do not be panic about this entire disease. If you behave responsibly, if you have if you take all the appropriate measures as advised by authorities and experts, you will minimize your chances of getting the infection. If you get the infection, again, do not panic. The medical profession is always there to hold your hands and help you. And we have good Smartans like Indrani and Mr. Ranganathan, who will always be around to help you and see that you're provided for in the long run. And the help will always be there from citizens of India. So thank you very much for inviting me. I really feel obliged to be part of the show. Thank you so much.
Thank you. Personally, Sanjay, thank you very, very much for being with us and your promise of being with us in the days to come.
Always be there.
Thank you. So Mr. Ranganathan, thank you also for joining me tonight. And we look forward to more work in future.
Fine.
Thank you all.
Thank you so much.
Thank you, Dr.
Good night.
Good night.